We know the future's hard to predict, but some trends we can forecast and foreshadow. Technology is going to play an increasing role, especially that's useful for rural and remote populations. And demand for palliative care services is only going to increase. One of the things I try to do in my keynote address is say, firstly, before we talk about palliative care, can we frame what the future might look like for all of us? So let's have a look firstly by framing palliative care by not talking about palliative care. Let's have a look at the world over the next 25 years and beyond. We know some things, but it's very hard to predict the future. We know technology is going to continue to advance. In fact, a colleague of mine was explaining just before that maybe 75% of all the jobs that your children are going to occupy and have don't even exist yet. Universities where I work, there's a knowledge explosion going on. There are many new things coming. They're going to play a great role in palliative care, but also other services that we receive. We're at the start of the revolution of buying books on Amazon and connecting via social media. As those things accelerate, the health system's going to exploit those. We're going to get faster broadband. We're going to be able to connect with each other more quickly. So the world is changing. That's a general frame within which I delivered my keynote address about where palliative care would fit in.
I think that Jeffrey Braithwaite showed some wonderful film clips about the potential future of healthcare. There were some wonderful clips about what technology can do, and I think there were some really clear messages there that even with all the fancy technology that we might have in the future, it still comes back to the person. It's really about person-centred care. That's what we need to focus upon, and that's what's most important. I think as technology develops, again, that is really relevant for the rural audience. It's very important that we utilise technology as much as possible to ensure that healthcare is delivered even when you're not near a big city, even when you're not near a regional centre. We need to make sure everybody has equal access to healthcare.
The issues facing palliative care, my take on this is that they stem from how do we fund the services, how do we resource healthcare more broadly, what about the training of health professionals, and generally a lack of discussion of death and dying in our community. One of the challenges with palliative care is the way it's funded. It's often funded in an episodic, fragmented way. It's going to be really useful if we can have better funding models to bring together funding to fund, say, a whole stream of palliative care services. Also keen in having, and this is of major benefit for rural and remote populations, having palliative care services delivered much more in a team-oriented way, rather than someone having to go to a general practitioner and then another provider, say 50 kilometres away. So how do we use technology, better funding models and multidisciplinary teams to deliver better palliative care? The moves are afoot to have people not be cared for in large tertiary teaching hospitals in intensive care beds, which are expensive and not the right place for many palliative care patients. To be frank, the place to die is in the community, with your family, even at home, if that can happen. In a way, rural and remote communities already have the seeds of the future of palliative care. They know how to do things with fewer resources than they have in the big city, fewer health resources. That's where ingenuity kicks in, and there's much more teamwork because rural populations are usually much more community-based. So in fact, I'd reverse the question and say, how can the big city tertiary referral places learn from the rural populations about how to cope with palliative care and death and dying? Choosing your own community, surrounded by your friends and family, surrounded by good providers of clinical care, that's a great way to be treated with dignity and respect as you move towards your own death. So a lot of people around the world think that we don't discuss dying. People are afraid They're not palliative care specialists themselves. Oftentimes, we don't want to think about that we might need palliative care or that, in fact, we're going to die. However, as we've had a theme in the conference, one thing is absolutely predictable. 100% mortality, we're all going to die. So one of the things we discussed is just how can we maybe have a social movement, a whole enterprise within society of understanding that it's in all our interests to appreciate that we're going to need palliative care maybe, that we're all going to die. What are our plans for the future? If we can make those plans as individuals, how our families understand what our preferences and choices are, the health system doesn't have to guess. The health system knows in advance what it is that we have decided we need. And if we have cancer and the disease progresses and we're in the advanced stages of that, then there's already a signal in the health system about how to handle that. We've expressed our preferences and choices. Otherwise, the health system, all it knows what to do is continue to treat you. And sometimes that shouldn't be done. It's futile. I woke up at 2 o'clock in the morning, early this morning, knowing what I was going to say, except I didn't know which story I'd use to illustrate palliative care. I dug a bit deep and decided to use the story of Raymond. Raymond was one of the little guys. He was born in 1928 in Newcastle upon Tyne in the UK. Like many people at that time, in the 1930s in the UK, he left school early to do a trade. He became a carpenter. He travelled, had kids, good life. He came to Australia in the 1970s. He prospered further. He had baby boomer kids that he was proud of who grew up. He had no health problems of any major consequence. He didn't know anything about the health system, despite members of his family being in the system and being quite knowledgeable. And then in his late 50s, he suddenly lost a bit of weight. He thought it was because he gave up biscuits for morning tea. But then he lost a bit more weight. He went to the doctor, a very good GP. Eventually, he was diagnosed with colon cancer. The medical machine kicked in. You know what it's like. The acute care machine kicked in. Radiotherapy, chemotherapy. His disease, however, progressed. Eventually, he found his way to Sacred Heart Hospice, part of St Vincent's in Sydney. This opened his eyes to palliative care. He met fantastic staff who cared for him. They treated him with respect and dignity, even though he was bewildered about the terminology and what happens in healthcare. They managed to bring him to terms with the end of his life. He died in 1991, aged 62 years, and he had a great life. But the last bit of his life ended up probably being as good, if not better, than all the rest of his life, because he had a great death. And he died, and I know it's a cliche, Raymond died surrounded by his family. This was profound. A person from humble beginnings, great life, knew nothing about the health system, but it was the health system, in fact the palliative care system, that enabled him to have a terrific death. Of course, you've guessed, Raymond was my father. He was treated with dignity and respect. He trusted the doctors and the nurses and the allied health professionals. And while you don't want to think about your own father's death or someone in your family, in hindsight I can see he really had a good death. I could wish that for many people, that they have a good death. I think we need new models for palliative care. Some of the funding, some of the way we fund care in Australia works against having a good collaborative model of delivering care. I think exploiting technology, Skype, Facebook, being able to keep in touch with people, being able to keep in touch with providers, personally controlled electronic health record where the patient is in control of their own health records, having more teamwork, including having the patient as part of the team, not just a team of clinicians to treat you, but the patient is an active part of the team. In fact, the patient is often the key decision maker. It's their body, it's their care, it's their palliation, it's their death. Here's to palliative care. A discipline, a field, an undertaking that supports the fabric of Australian society. Here's to its future. Thank you very much.